Hi everyone, thank you for joining us again for the monthly Orthotic webinars on various conditions and prescriptions. So today we're going to go through bunions, joint fractures, lateral column overload and medial tibial stress syndrome. There's actually 6 in total that we're going to go through today because both bunions and Jones fractures have 2 different templates. So I'll start by sharing my screen. So we're going to start with bunions. We've got 2 templates. One for when we've got good range of motion with the bunions and not really any pain. So we're more sort of dealing with the aesthetic nature of the bunions and trying to prevent them from getting worse. So you'll notice when we go into the templates, we've got good range of motion. So also under HAV, so you can also search under HAV and those will also come up. So for those of you who are not familiar with our template system, you can type anything into the search function here, whether it be, a foot type, a shoe, cycling shoes, football boots, various conditions. So we've got about 155 templates now. We keep adding new ones as we come across new, well, not new, but come across templates that we don't have up there. So we're going to start with the good range of motion. So as with most of our templates, it's difficult for us to tell you what the rear foot correction should be and the design should be. That's going to come down to your foot posture index, your supination resistance, Jack's test, foot type, etc. Medially deviated subtalar joint axis. So most of them, unless it's a specific orthotic for a pes planus foot or a medially deviated axis, are going to have 4 degrees and our most common midfoot controlling device. However, the moderate part first rate fill or design here is relatively important when we're dealing with bunions that are not painful. So generally we're wanting to allow that first ray to drop and plantarflex and build up underneath the lesser metatarsals and prevent pronation. And one of the ways in which we allow that first ray to drop is by using the part first ray fill. So for those unfamiliar with our designs, the part first ray fill takes away contact from the first ray. So you look at the mod root, it's quite parabolic and full anteriorly. So you don't want to use this device if you want the first ray to drop. So we've gone for the part first ray fill to allow that first ray to sit dropped. And then next thing we're going to look at is a first MPJ cutout. So again, we're creating additional space for that first met head to sit in. The material for the shell, I don't have a particular material to recommend for this this condition. If they were sporty and playing basketball or netball and a lot of side-to-side movement, I'd lean towards a Poly-X because it's a bit more forgiving, it's a little bit softer. However, that's going to come down to the nature of what the patient's doing. The next thing of importance here is your reverse Morton's extension. So we've gone firm EVA, 3 mil. You could push that up to 4 or 5 mil, depending on how much room you've got in the shoe. So using the midfoot controlling device, we're supporting the arch. The part first ray fill, we're allowing the first ray to plantarflex. The first MPJ cutout, we're creating an additional hole for that first MPJ to sort of sit in. And then your reverse Morton's, which most of you would know what that looks like. But if you're unsure, you can always click through on our website and go to your reverse Morton's extension. So that is full thickness across met heads 2 to 5. And so you're just offloading the medial first MPJ and the hallux itself. So that's the one where there's no pain and you've got good range of motion through the first MPJ. The template for where you've got restricted range of motion, maybe it's painful osteoarthritis in the first MPJ, some form of sort of hallux limitus, then it changes slightly. So you see there we've moved into the mod root. So what we're essentially doing there is giving the first metatarsal support. And so upon ground reaction force, we're actually going to be dorsiflexing the first ray, which you don't want to do if you've got good motion or good range of motion through the first MPJ. You want to initiate that windlass. You want the first ray to drop. You want windlass to kick in. But if that first MPJ is arthritic, then generally we want to give it a little bit of dorsiflexion. And then the next thing that's important to do is to put in your Morton's extension. We've gone long and wide with this Morton's extension, so I'll just quickly jump into the Morton's extensions to show you. So the reason we've gone for normal and wide is that with that HAV, essentially that joint or the first ray deviates medially and then the hallux deviates laterally. So this just covers more of that first MPJ. You can do it in a long one as well. So either go for the normal and wide or the long and wide, depending on how long you want that extension to be. And then the other thing that you want to consider, again, material comes down to what they're doing. The other thing to look at is a carbon fibre spring plate, and you can either do that in the form of a, in the form of a modified carbon fibre spring plate in the form of a Morton's extension, or a full rigid or semi-rigid carbon fibre spring plate. So essentially that sits in the shoe as they walk. It aids in that propulsion forward, taking pressure off the first MPJ, so you don't get that extension of the hallux or dorsiflexion of the hallux or the lesser toes, and it aids in that propulsion forward. And that's going to come into play in a couple of the other templates we're going to go through. So similarly with a Jones fracture, sometimes you want to support it. So if it's due to a lateral column overload, which we'll talk about in a moment, or whether it's due to a twisting sort of fracture. Some people like to support it. Some people like to completely offload it. So there's certain padding you can do in the shoe to see which one is going to be better prior to ordering the orthotic. If you're unsure, I would go for the supportive one first, because we can always modify the orthotic and offload it. It's harder to do the other way around. So if you're going to support it, then we're looking at adding in lateral column support, extended forefoot valguses. So generally, you wouldn't be adding too much rear foot correction unless you're dealing with a pes planus foot type and you need to. But inverting the rear foot is only going to put pressure on the lateral side onto that styloid fifth ray Jones fracture. So if you want to support it, the first thing we look at doing is building in an intrinsic forefoot valgus, and that is going to support the wrong button. That's going to support the lateral column distally. So that's your intrinsic forefoot valgus, 3 or 4 degrees. It elevates the lateral column, bullnoses down behind the fifth MPJ, and just offers some support to that fifth ray. And then again, 3D print PolyX carbon composite comes down to what they're doing from an activity point of view. And then your extended forefoot valgus there. So we've gone for a soft EVA. So in most forefoot valguses, reverse Mortons, we're trying to create directional change, maybe move from a low gear loading into a high gear loading, forcing forces to move medially. But the reason we've gone for a soft one here is that we don't want to be too aggressive underneath that fifth ray in a Jones fracture. And 4 mil. So that's going to support that lateral column. And then obviously cushioning it is important. So 3.2 mil pour-on. We've gone for a 3 mil soft EVA. Keep in mind that that's going to be quite thick on the lateral side. So I've got 4 mil of EVA plus 6 mil of cover. If that's going to be too thick, then just reduce the thickness of the EVA cover or the poron or the forefoot valgus. And again, with both Jones fractures, we'd recommend looking at a carbon fibre spring plate. So it just takes the pressure off, prevents that plantar flexion, and aids in that toe off and toe spring. So for those of you who aren't familiar with them, there's straight and there's tapered. The tapered ones actually drop down and kick up in the toe box, so they act as like a little bit of almost like a rocker bottom sole within the a rocker bottom shoe, sorry, within the patient's shoes. And then the offloading one will be a 5th MPJ cutout. So earlier I said, if you're unsure, start with the supportive one because we can modify it. So again, we're not putting any rear foot because we don't want to put pressure on the lateral side. There's no point putting in a forefoot valgus if we're going to remove that part of the shell. So essentially the only change here is no forefoot valgus, and in the notes, 5th rate cutout in the shell of the orthotic. So, and then again, your carbon fibre spring plate is going to help with that toe off and propulsion forward. Okay, getting into lateral column overload. So it's a general term, not necessarily a condition, but I'm going to step through the lateral column support that we offer. So with this template, I've opted for 0 degrees in the rear foot. Depending on the foot type, you may want to add in a valgus correction in the rear foot of, say, 4 or 5 degrees. So that's something you may need to change. We're adding in forefoot valgus as well to support that lateral column. Again, the design's important. There's no point in going for a mod route, offering all this midfoot and forefoot lateral control and then counteracting it by building up the distal arch medially underneath the first ray. So that's a pretty good design. You could move into your mid-inverted as well, and the high point starts to become further back, which is important when we're trying to transfer the forces from lateral to medial. Medium or low arch, depending on a few other factors, amount of pronation, etc. So with a medial knee OA where we're using a lot of lateral forces, we tend to drop that down to a lower arch, but it will depend on a few other factors. We've got additional heel expansion here. Generally with any of your laterally controlling orthotics, so medial knee OA, cavoid feet, lateral column overload, we'd like to put in a little bit of additional heel expansion. We've added in a lateral curvy skive, and I'm actually going to bring up a CAD design of this orthotic that we're going through. So we've got lateral heel skive, cuboid notch, and intrinsic forefoot valgus. So what that looks like within the orthotic shell, I've removed the heel post just to show you. So instead of everting or adding a valgus rear foot correction, we can add a lateral skive. So you can see that's on a 15-degree angle, and that's 4 mil into the cast. We've then, forward of that, we've got a small cuboid notch. So you can see that cuboid notch. So the lateral heel skive transitions into the lateral cuboid, into the cuboid notch. And then we have a lateral cast grind. So if we go back further down here, we've got a lateral cast grind of 6 mil. So you can see that is that part there. And then we've also incorporated a intrinsic forefoot valgus. So the forefoot valgus just extends that lateral column a little bit further, and then bull noses down and drops down behind the first MPJ. So there's sort of all the intrinsic lateral column support that we offer. And then you start to add on extrinsic additions. So rear foot post, you could add on a lateral rear foot post, so just have it laterally and nothing on the medial side. And then we've got our forefoot valgus. So again, normally we would put in a firm EVA. However, given we've got lateral column overload, whether it be the cuboid, fifth ray, fourth ray, that's tender, we've dropped that down a notch to a medium and added in a 4mm forefoot valgus. So the sulcus length forefoot valguses essentially look the same as the reverse Mortons I went through earlier, but they're tapered. So if you zoom into these images, the reverse Mortons is full thickness through there, 2 to 5. This one's tapered down, so it's almost 0 underneath the second. And it's not on this template, but you may want to consider again carbon fibre spring plates for that toe off assistance. So, okay, how are we going for time? 10 minutes. All right. So moving on to, if there's any questions, just feel free to raise your hand. So moving on to medial tibial stress syndrome. So also for those of you unfamiliar with our platform, if this is your first webinar with us, you can create or change any of these templates to suit you. So you can go into our medial tibial stress syndrome, and you can clone it and make a few changes. So if you like 80% of what I'm saying and want to change a couple of things, that's fine. Feel free to change these templates and make them your own. When you make them your own, they're only available to you in your portal. If we create them based on what the market's doing and what we know is working anecdotally, then if we post them, they're available for everybody. So with this condition, we're generally dealing with some sort of inflammation of the periosteum, resulting in, from tibialis posterior and or soleus. So under the tissue stress model, we're trying to assist those muscles, which are, they both invert the foot and plantar flex the foot, and they're also involved in resupination. So how do we assist the tib post? First thing we want to do is look at inverting the rear foot to assist with that, inversion of the foot. For this one, I've chosen a mid-inverted. So again, it's going to be foot type specific. If they've got a medially deviated subtalar joint axis, which wouldn't be uncommon with a medial tibial stress patient, then you may need to move to an inverted or a true inverted and increase that rear foot further. Again, for those of you who are new, you can go in here and have a look at mild, moderate, and severe recommendations for mid-inverted. So if we're looking at a mental blank foot posture index of, say, 7, you'd be looking at sort of mild to moderate. If you've got a foot posture index of 10 or 11, you might be looking at severe. 12 is very severe. So that foot posture index can be one way to sort of look at the amount of rear foot correction that you want to add into these different devices. Well, I haven't filled in the arch. I'll be looking at medium or high, so we want to assist in that inversion of the foot. So we'd want good control, especially underneath the navicular, which is where the mid-inverted orthotic will peak. So the tib post is also a foot plantar flexor. So am I in the right one? Sorry. Sorry, I thought I had heel raises on this. I'm going to add the heel raises in now. So to assist in that plantar flexion, Heel raises are not a bad idea. It also assists soleus, which can be part of the medial tibial stress problem. And then again, carbon fiber spring plate. So because tib post is also a foot plantar flexor as well as an inverter, then going back to that sort of tissue stress model, if we can assist in the inversion and the plantar flexion, then we enable that sort of muscle to heal, or in this case, take pressure off the periosteum. So heel raises to help with the plantar flexion, rear foot inversion to help with inverting the foot, and carbon fiber spring plate to also assist with that plantar flexion that happens during toe off. So again, a tapered spring plate that assists in that toe off will take pressure off the tib post. I've got one other note here, which you may also want to consider a reverse Morton's extension. So I'm going to add this. Hey, Tegan. I'll stop sharing my screen and go to questions in a minute. So you may want to look at adding a reverse Morton's extension. So what that does is allows that first ray to drop because you're supporting met heads 2 to 5. And by dropping the first ray, you're then going to initiate that windlass mechanism earlier. So you're going to resupinate, again, assisting the TID post. I'm just going to fill in this template. I'd use firm EVA because we're trying to create change, 3 or 4 mil, depending on how much room you've got in the shoe. Yeah, and for those of you who want assistance with orthotics, if there's conditions on here that we don't have, then often we'll just create a template for you and publish it for a while for you to use, and unpublish it if we don't want to keep it up there. I'm just going to stop sharing so I can see questions. Could improperly prescribed orthotics exacerbate lateral column overload? I would say yes, if you're inverting the patient more than is necessary, or using sort of mod routes when the health of the first MPJ is fine. So theoretically, if we're dorsiflexing the first ray, we're delaying that windlass. We're pushing forces from medial to lateral, which is going from that high gear loading scenario where we're using our longest lever being the hallux to propel forward, and pushing it laterally to low gear loading, which is, I guess, less efficient. So, and there's plenty of studies about low gear loading creating issues like lateral column overload. Another question, are there any common pitfalls to avoid when fitting orthotics for patients recovering from a Jones fracture? One thing I didn't talk about with the Jones fracture was looking at using lateral EVA arch fills. So I'll just share my screen for a minute. So on our orthotic additions on our educational website, you've got all these 28 most common additions, but you've also got additions in notes, and we're constantly adding to that as well. But you've got a lateral EVA arch fill, which essentially does that, and on the lateral side looks like that. So if you're trying to support that, whether it be Jones fracture or lateral column overload, because this lateral arch is quite low and parabolic, you put your thumb on it and the lateral arch will collapse pretty easily. Not so much so on the medial side because it's a higher parabolic arch. So whenever you're trying to support on the lateral side, be it the supportive Jones fracture or be it the lateral column overload, putting in an EVA arch fill to reinforce what you're doing is often a good idea. So even if you're doing that offloading Jones fracture prescription where you've cut out the whole fifth ray, you can actually do an EVA arch fill all around it, because the last thing you want to do is cut out the fifth ray and then have the whole lateral column collapse anyway. So adding in that lateral EVA arch fill is important. We've decided not to 3D print it in because it is very firm and it's very difficult to grind out if it's 3D printed. So using a medium or firm EVA, you can easily adjust it, and we find that works much better. So they were the two questions that were asked. What have we got? 3 minutes. Did that one pretty quick. I thought I was going to go overtime. Are there any other questions? If there are, and you think of them later, feel free to reach out to Orthotech, hello@orthotech.com.au is the best email to send questions through to, and we'll come back to you. Otherwise, thank you very much for jumping in, and we hope to see you in another month for our next webinar. Thanks, guys.